Okay, for this presentation, I'm going to introduce you to abnormal uterine bleeding. This will be, as all the presentations, brief and certainly not meant to be your only resource as you're learning about this information. Now, the term abnormal uterine bleeding has recently been changed. The more traditional terminology is dysfunctional uterine bleeding, but that really didn't capture the essence of the problem. And abnormal uterine bleeding better describes what the problem that so many women in at least our society has. Now these are some of the older terms for abnormal uterine bleeding, and my gut feeling is you're going to still see these terms quite often. However, in the next slide, I will show you the new terminology, which is just more descriptive and not nearly as confusing as all of these terms. These terms are so easy to get mixed up and misunderstood, and certainly our patients never understand it. Historically, menorrhagia or hypermenorrhea indicated that there was a prolonged and or excessive uterine bleeding occurring at regular intervals. So if it was menorrhagia or hypermenorrhea, they were regular, but they were over 7 days long, or they were excessive in the amount, which is classified as greater than 80 milliliters. Menorrhagia is uterine bleeding occurring at completely irregular but frequent intervals, and the amount could be variable. It could be excessive, but it could be just spotting. Now, menorrhagia is when their uterine bleeding is prolonged and it occurs at completely irregular intervals, while polymenorrhea is uterine bleeding at regular intervals of less than 20, occurring every 21 days. Intermenstrual bleeding is a term that you'll still see, and that's bleeding of variable amounts occurring between regular menstrual periods. Oligomenorrhea is uterine bleeding at regular intervals, but those intervals were extended or are extended from 35 days to 6 months. Amenorrhea is a term we will continue to see. It's absence of uterine bleeding for greater than 6 months. Postmenopausal bleeding is uterine bleeding that occurs more than 1 year after the last menses in a woman with ovarian failure. So it's really not menopausal bleeding unless the woman went a full 12 months without having a menstrual period. Okay, now the terminology that we're using is abnormal uterine bleeding. And this is the #1 reason that women present for GYN visits. It is about 25% of all the visits to women's health practitioners or to practitioners where there is a complaint of GYN in nature. And this constitutes about 20 million visits each year. It includes that term abnormal. Uterine bleeding is a term that's used for any change in the menstrual period. So it's far more encompassing of all the complaints that the woman may have, or all of the symptoms that a woman may have. It's just more universal as far as any abnormal bleeding. The other names are going away. I think just like everything in healthcare, it's going to take a while for practitioners, including myself and maybe some of you, to get away from some of these terms. But they should be going away. They're not supposed to be used anymore, but they probably will be for a while. What's happened with the change in the terminology is that now the names aren't so confusing. Instead of menorrhagia, it's heavy menstrual bleeding. We say that there's a duration of greater than 8 days, or a frequency less than 24 days, which previously was polymenorrhea, or intermenstrual bleeding, menorrhagia, and that term menorrhagia should also have a line through it because that is a term that's no longer supposed to be used. So again, these terms are far more descriptive, easier to understand, easier for us as healthcare providers to remember, as well as easier for our patients to understand what we're talking about. Okay, in 2010, there was a new classification system that was devised for classifying abnormal uterine bleeding. And what they did was they broke out the causes of abnormal uterine bleeding into those that are structural. So there is a structural issue that's causing the abnormal bleeding, and the non-structural. So other causes that wasn't some anatomical reason for the bleeding. The structural causes, now in both cases, they were able to define or use mnemonics that will certainly help all of us remember the causes of abnormal uterine bleeding. For the structural causes, the mnemonic is PALM, as depicted in this photo. And the P is standing for polyp, A is adenomyosis, L is leiomyoma, and M stands for malignancy and hyperplasia. So what you'd see is AUB/P, meaning it's abnormal uterine bleeding caused by a polyp. So those are the structural or the anatomical causes of abnormal uterine bleeding. And then for the non-structural or non-anatomical, the mnemonic COIN is used. Now they threw in an extra letter, so you have to just go along with the mnemonic and remember that in this case COIN has an E that is stuck right in the middle of the mnemonic. So C stands for coagulopathy, O is ovulatory dysfunction, E endometrial, I iatrogenic, and N is not yet classified. And in your readings for this week, I have included the reference to the new FIGO classification system where all of these are further defined and discussed throughout that document. Plus, as you're doing your discussions, I think you'll find that there are at least a few additional documents that are being published now related to the FIGO classification system. So looking at these a little more closely, the structural pretty much speak for themselves. Let's go back and look at those. Polyps, adenomyosis, leiomyoma, malignancy, and hyperplasia. All of those we can image or do a biopsy and we have our diagnosis. And that's as compared to the non-structural, which we have to use a little bit more diagnostic reasoning to even determine what testing we need to do. So the first of the non-structural is coagulation disorders, or the AUB-C. This is actually far more common than we previously thought or believed. There is an inherited coagulopathy as the cause of abnormal uterine bleeding in 18% of Caucasians and 7% of African American women. Now that's pretty high as far as the cause of abnormal uterine bleeding, 18% of Caucasian women. Now because this is a genetic or an inherited problem, most commonly these abnormal uterine bleeding problems are going to present in adolescence at the early onset of menses. Von Willebrand's disease is the #1 etiology of inherited coagulopathy. And the von Willebrand's disease itself occurs in about 1% of Caucasians, but again, coagulopathy is the cause of abnormal uterine bleeding in about 18% of Caucasians who present with abnormal uterine bleeding. Now, the other non-structural, or the AUB-C disorders, include blood dyscrasias, that's no surprise, such as leukemia, idiopathic thrombocytopenic purpura, or ITP, liver disease, or kidney disease are both related to the AUB-C. Now, the acquired coagulopathy is much more rare. So we don't see the acquired as often as we see the inherited. And again, we're seeing the inherited far more than we previously thought was the case. Okay, the O stands for ovulatory dysfunction, the AUB-O. This is formerly what we call the dysfunctional uterine bleeding. The most common cause of AUB-O is anovulation, or the woman just is not ovulating. And it's at ovulation that we start seeing the increased progestin production. And it's the progestin production that then is going to cause the eventual sloughing of the lining of the uterus, which causes the menses. So it stands to reason that if we don't ovulate, we don't produce the progestins. If we don't produce the progestins, we have nothing that is going to stabilize the uterus and stabilize that growth of uncoordinated shedding. Ovulatory dysfunction, or the AUB-O, usually results in irregular cycles, and they tend to be heavy and long in duration. And one problem, in addition to the abnormal uterine bleeding, or the ovulatory dysfunction, is that we not only have these irregular, heavy, long, nasty menses, but the unopposed estrogen can actually lead to an increased incidence of endometrial cancer. If that progestin isn't stabilizing the uterine wall, causing the shedding as the wall increases in its mass and size, now we've got this big, thick, heavy uterine wall, which is more conducive to those cells within the uterus becoming dysplastic and finally neoplastic. And this is the menstrual cycle. It is just depicting what I just told you about, that with the menstrual cycle, notice that early, the first 14 days, we have this buildup of estradiol, and at the same time as the estradiol, during this phase, when the estradiol increases, we also see the proliferation of the uterus. And then ovulation occurs. As soon as ovulation occurs, we have the secretion of the progesterone, we have less estradiol, and as the progesterone increases, then it causes the breakdown and the sloughing of this uterine wall, and eventually we're going to have menses occur and the actual sloughing off of those cells, just to get ready to start the cycle all over again. Again, the unopposed estrogen, where we have the output of estrogen but not the progestins, we're going to increase our chances for endometrial cancer. If ovulation does not occur, we also are going to see the lining of the uterus become larger and larger and larger and larger until it essentially breaks loose, and then we have that very long, very uncomfortable menstrual period. Okay, common etiologies for abnormal uterine bleeding related to ovulation. I've already mentioned anovulation. Obesity is associated with anovulation. Other hormone imbalances such as polycystic ovarian syndrome, which we will be talking about more, I think, in 2 weeks. Perimenarche or perimenopause are both periods in which we see, are both times in our lives that we see periods of anovulation. And then the other common etiology for AUBO are the endocrinology or the endocrinopathy. And that hyper or hypothyroidism can be the culprit in anovulation or in AUBO. And pituitary or adrenal pathology can also be associated with the ovarian causes of abnormal uterine bleeding. Now, remember, thyroid problems, either hyper or hypo, can cause any menstrual disorder. So, essentially, if we have heavy bleeding, consider thyroid. If there's no bleeding, consider thyroid. If there's irregular bleeding, consider thyroid. And it's really a very simple blood test to get. And it's also a fairly simple fix to put these people on thyroid replacement hormone, or if they're hyperthyroid, to do some type of ablation or medication to decrease the secretions from the thyroid. The E stands for endometrial causes, or AUBE. Some of the common ones are endometritis, or inflammation of the endometrium. And then if we have disordered endometrial hemostasis, usually this is associated with abnormal prostaglandin synthesis. The I is iatrogenic, and essentially iatrogenic includes all those drugs that we give them that may have an impact on the menstrual cycle and cause the abnormal uterine bleeding. This includes the hormones, the oral contraceptives, the combined contraceptives, hormone replacement therapy or estrogen therapy in our postmenopausal women, corticosteroids themselves. The women may be taking corticosteroids for some reason completely unassociated with GYN issues, but end up with some abnormal uterine bleeding. Psychotropic drugs are common culprits in abnormal uterine bleeding. Not surprisingly, anticoagulants. The NSAIDs can be an issue with the abnormal uterine bleeding. And then always think or talk to your patients in terms of possible complementary medicine. Ask them what they've been getting at their local health food store, because herbs and botanicals, especially soy, but also ginseng and ginkgo, have been related to the abnormal uterine bleeding. And then there is the N, which is not yet classified. So essentially the more rare causes, I'll go into this, not yet classified, which I suppose in the future we might find out that those that we think are fairly rare are actually not so rare, like the inherited coagulopathies. So what do we do about abnormal uterine bleeding? Well, FIGO has some recommendations for treatment of chronic abnormal uterine bleeding. Please note that if it's not 3 months or more of excessive duration, excessive volume, increased frequency, or unpredictability, then we can't call it chronic abnormal uterine bleeding. So before we do anything, for their symptoms that they're experiencing of abnormal uterine bleeding, we wait 3 months because the woman's body is pretty good at readjusting itself and taking care of these issues. But if it's more than 3 months, of symptoms, then we will start investigating. And our evaluation is going to be, not surprisingly, broken down between structured history, asking specific questions, doing a physical exam, and then that physical exam includes our clinical exam, the visualization of the cervix, the bimanual exam, but it also includes uterine evaluation, some of the tests we will do to evaluate the uterus. And then the ancillary investigations includes our blood work. We're going to get a complete blood count on our patients with abnormal uterine bleeding. Obviously, we want to know if they're becoming anemic or not. But just as important, we want to know if they're becoming anemic because the abnormal uterine bleeding, as the hematocrit drops, there is less oxygen supply to the uterus, which seems to then further increase the bleeding and the blood loss from the uterus. So if we have some AUB and the patient is getting anemic, we want to treat that anemia because overall we're helping to decrease the blood loss in most cases. So the complete blood count is going to be important. Evaluating endocrinopathy and testing for inherited coagulopathies if indicated. Okay, this one is a little bit busier. I think it's much busier and hard to follow. So essentially, what the guidelines for the uterine evaluation. Remember I talked about the pelvic exam, probably doing a PAP on these women. We also may determine that we need to do the uterine evaluation, and in determining what type of evaluation we need to do, then we ask ourselves, based upon the history, is this woman at increased risk for hyperplasia and or neoplasia? If the answer is yes, then the next step would be office endometrial biopsy, which many nurses, especially women's health nurse practitioners are doing endometrial biopsies, but we're seeing more primary care NPs. Once we've got an adequate specimen, then they check. If we are doing the biopsy, we're wanting to check for atypical hyperplasia and or cancer. And if that is positive, then we're going to manage their AUBM. If their specimen is negative for atypia or hyperplasia, we're going to have a presumptive ABUE or AUBO. Now, so that's if there's a history or something that makes us suspect hyperplasia or neoplasia. If they have an enhanced risk of a structural abnormality, then we're going to take the vaginal ultrasound route and perhaps a hysteroscopy with or without a biopsy, and maybe consider an MRI. Laboratory evaluation of abnormal uterine bleeding. We're going to do the history, we're going to do the physical exam, and the laboratory evaluation. Anytime we have a patient with abnormal uterine bleeding, essential tests, a test for all patients is to rule out pregnancy. The other two simple tests are going to be the complete blood count and the thyroid stimulating hormone. Coagulation tests if indicated, and if we determine that we need to do a coagulation test, and actually the FIGO reference that I gave you has a nice chart on who you're going to consider at risk for coagulation problems. If you run the blood work, you're going to run platelets, protime, partial thromboplastin time, fibrinogen plus the von Willebrand factor antigen, the von Willebrand factor activity, which is also called the ristocetin cofactor, and check factor 8 to diagnose or rule out coagulopathies as the cause of your AUB. Chemistry screen if indicated, and what you're looking for here is to check the chemistries to determine liver function and kidney function. And finally, if polycystic ovarian syndrome is suspected, you want to get your androgen studies, your DEHA, or the 170 HP. Additional testing, if they're ovulating, if their history indicates that they are ovulating, then an endometrial biopsy would be indicated, especially if the women are greater than or equal to 45 years of age. In obese patients, diabetic, hypertensive, and polycystic ovarian syndrome, then, well, if they're ovulating, you're going to look for and do some counseling for obesity. You're going to treat diabetes, hypertension, as well as their PCOS. Now, with the endometrial biopsy, what our findings are going to indicate to us is that when the biopsy is sent in, you'll get the report back that it's either proliferative or secretory endometrium. And essentially that means that if it's proliferative, if the endometrium is continuing to proliferate, then that's an indication that they are not ovulating. But if it's a secretory endometrium, then it indicates that ovulation is taking place and that the uterus is sloughing off and stabilizing. The biopsy is also going to tell you whether there's hyperplasia with or without atypia and endometrial cancer. You can identify chronic endometritis with the biopsy. You can identify atrophic endometrium. And then there are always those cases, wouldn't you know, that the result comes back insufficient for diagnosis, and then you have to do further testing. Okay, additional testing includes the transvaginal ultrasound. And what you're doing with the TVUS is to rule out endometrial pathology, such as the fibroids. This is the endometrial anatomical structures that's causing the abnormal uterine bleeding, including the fibroids, ovarian pathology, or endometrial polyps. Also, with the TVUS, you can measure the endometrial stripe. This is very helpful in postmenopausal women because it's very reassuring if the endometrial stripe or the wall of the endometrium is less than 5 centimeters. It's not as helpful in premenopausal women because of the fluctuation in the wall of the uterus, but so if you're going to do ultrasound testing, make sure that it's after the withdrawal bleed or after the patient has had a period. Saline installation, which is the sonohysterography, is useful in evaluating the intracavitary abnormalities. Actually, by installing the saline into the uterus, it kind of expands things, and it's much easier to see those fibroids or the endometrial polyp. And in the meta-analyses that have been done as well, I can just say meta-analyses because they've looked at all of the studies that meet the criteria, it's found that the saline installation is superior to the transvaginal ultrasound. And then additional testing, and these you will be referring for the hysteroscopy. This really gives you a definitive diagnosis. They can go in and look at the uterus itself, get samples or biopsy. Also, if polyps or fibroids are found with the hysteroscopy, they can go ahead and treat that by excising the polyps and fibroids. MRI is rarely needed, but it can help to further characterize pelvic and intrauterine lesions, the penetration depth of the fibroids, and it can help to rule out the leiomyosarcoma. So how do we manage acute abnormal uterine bleeding? Now, take note. With abnormal uterine bleeding, we have acute and we have chronic. So right now, talking about the acute AUB, it's important that we recognize it and recognize it early. Women with acute AUB have been known to go into severe shock while waiting in the doctor's office. So it can be a medical emergency, in which case these patients are usually hospitalized with frequent monitoring of vital signs, just like we would any patient that's hemorrhaging, IV fluids, and type and cross match, and administer blood replacement if necessary. Other treatments for the acute abnormal uterine bleeding, which can be going on at the same time as the life-threatening measures or the emergency measures of vital signs, fluids, and blood replacement, would be the administration of Premarin, 25 milligrams IV every 46 hours times 24 hours, or Premarin 10 to 20 milligrams PO in 4 divided doses over 24 hours. Premarin is evidence-based, and what it does is that it helps the uterus to heal over. Even though Premarin does have some estrogen in it, the estrogen helps stabilize that uterus, and then of course the progestins are going to help or cause the uterus to stabilize and eventually slough off. After we stop the Premarin, it's really important to advise the patient that they will expect heavy bleeding. And if for some reason we want to biopsy that uterus after the acute AUB, we biopsy the uterus after that withdrawal bleed from the Premarin. Now, more likely what you're going to see in your office is the patient has an acute AUB, or abnormal uterine bleeding, but they present in stable condition. Their blood pressure is stable, their skin is warm and dry, and they're not passing out and dying in your waiting room. And when they present in stable condition, then the treatment will be 30 to 35 micrograms of a combined oral contraceptive pill. If for some reason they cannot take estrogen, maybe it's because they have a blood dyscrasia, or maybe it's because they're on oral contraceptives already, and the oral contraceptives may or may not have been terribly helpful. But if there's some reason that we shouldn't give them the estrogen, then we can give them progestins alone, like the norepinephrine acetate 5 milligrams or the medroxyprogesterone acetate 20 milligrams, TID times 7 days. Now this is the norepinephrine or the medroxyprogesterone, TID times 7 days, and then we slowly taper that to a daily dose. And we continue that daily dose from 3 to 6 weeks. Then a new treatment is the tranexamic acid, where we are going to give 2 600 milligram tablets TID times 5 days in the treatment of the acute abnormal uterine bleeding. And I'll talk a little bit more about that when I talk about the management of the chronic abnormal uterine bleeding. It's a great drug. It's been found to be very effective, but it's very expensive, almost cost prohibitive. Okay, so management of chronic abnormal uterine bleeding. These are the patients we're really going to see more often. And it's going to be general health measures such as weight control and giving them iron supplements to help treat their anemia. And remember, not only are we treating their anemia and blood supply to the rest of the body, we're treating the blood supply to the uterus, which is also very helpful in controlling bleeding just simply by getting the hematocrit up. It's believed that the heavier bleeding is the result of decreased oxygen supply to the ovary. Another treatment is going to be the NSAIDs. NSAIDs it's the antiprostaglandins of the NSAIDs that close the arterioles that actually feed the endometrium. So it causes some vasoconstriction of those arterioles that are feeding the endometrium. And it will decrease the blood loss by 20 to 30%. So pretty good response. A better response is the tranexamic acid, or Lysteta, which has been found to be superior to the NSAIDs. In fact, its effectiveness is about 50% in decreasing the blood. The Lysteta works actually by stopping the fibrin breakdown, which then stabilizes the clots. And the treatment, or the dosage, is again 650 milligram tablets TID times 5 days every cycle. Now this can get very cost prohibitive, and so it's often used just as a bridge until longer-term therapy can be started for these patients. It's very effective, very expensive, and it's also contraindicated in all patients with thrombophilia or with all patients who are already taking oral contraceptive pills. In both cases, the woman is already prone to more increased risk of clotting, plus now we're going to stabilize those clots, and we put them at an increased risk of deep venous thrombosis and or pulmonary embolism. You might watch for that. I don't know that you're going to see a lot of Lysteta in your practices, but that's a pretty important piece of information to have. So you might see that on the quiz or the final exam. And then further management of the chronic AUB is progestins. The progestins are going to decrease the bleeding by stabilizing the endometrium. They help to prevent the endometrial cancer. The woman can get their oral contraceptives or can get their progestin in their oral contraceptives if the combined oral contraceptives are not contraindicated, and such as women over 35 who are smoking, or a woman who already has a blood clotting issue. Progestins can be obtained through cyclic progestins, the norethindrone acetate, the medroxyprogesterone. Progestins can be delivered through the progestin-only contraceptions, such as the progestin-only pills, the Depo-Provera, and the most effective is the levonorgestrel intrauterine system, or Mirena. In fact, the Mirena has been found to be as effective for AUB as endometrial ablation, and it probably has some benefits above and beyond the endometrial ablation. Because when we're considering endometrial ablation, obviously this is a patient that has to be referred. Many women's health nurse practitioners and increasingly more family nurse or primary care nurse practitioners are starting to insert the intrauterine system or the Mirena. So we're going from a cost of the insertion of the IUS to having a surgical procedure done. Then there are other issues we have to consider with endometrial ablation, such as answer the questions, has endometrial hyperplasia and cancer been ruled out? Because before the ablation takes place, we need to rule out the hyperplasia and the cancer. We have to consider patient expectations and make sure that she understands that she will still need to use contraception. She needs to understand that she may be, no guarantees, but she may be satisfied. She may be resulted with a reduced blood flow, or 23% of the women who have had ablation have amenorrhea. Patient teaching should include that 16 to 40% of them will need further treatment within 5 years. So choosing the ablation is not going to be a lifelong answer to the problem of the abnormal uterine bleeding. And also in referring a patient, we need to remember that the highest failure rate for ablation is in that population of women who are less than 45 years of age, or the women with parity of more than having 5 live births.